So racial and ethnic differences, according to the IOM, in the quality of health care, they are not due to access-related factors or clinic needs, preferences, or appropriateness of intervention. Now, I have a little bit of problem with this definition because I look at our own system. And one of the things you'll see about healthcare systems in urban areas is really poor access. Okay? And why? Because it's sort of it's just not an issue. If you're out in the suburbs or you're out with people lots of insurance and this, that, and the other, you build systems in place because you feel there's a business case for servicing people who are worth more. That's the only thing I can think of. So when I tackle this problem in our department, I had people look at me like, why are you worried about this? I'm worried about it for a couple of reasons. Number one, access, poor access, is going to be part of the reason that you are going to see disparities. We have some of the best doctors around. We have a huge concentration of top docs, best docs, super docs. And we're sitting there and it takes you 16 weeks to get into one of our divisions. What really hit home with me is at my daughter's wedding, my dean emails me and says, I need you to look into something. So I'm sitting there at my BlackBerry looking at this, and it almost fell out of the front seat of the SUV. It was actually someone with a mass on a scan who very likely had cancer and waited 8 weeks to see one of our doctors. So my motto is if what we should be doing as practitioners and people involved in systems of care is we should really try to build systems of care that are what we want for ourselves and our families. And if we don't want to do that, then we've got a problem. It's okay if you're not there. What's not okay is if you're not working to get there. And so we systematically took on an access program. And again, it's not health literacy, but I think it is important. So we took on an access program where each of our divisions had to figure out a way, in working with our schedulers, that they were going to improve access. And we've had a lot of success. I'll also tell you that from a business perspective, it's also good business too. Okay? And it's one of the times where doing good business is totally overlapped with doing the right thing. Sometimes those two are kind of opposite. But we took that on and have had success with it. So I like the IOM definition except for the access part, because access is going to be differential by where you live. Now, my take on racial and ethnic disparities, and I choose cardiovascular disease here, is that in actuality, when you look at most disparities, everybody's kind of getting a bad deal. Some people are just getting worse, okay? There's a problem everywhere. So if we're in the healthcare system, you've got to really have a commitment to quality overall. Now, you don't want to have quality just raise the bar for everybody and keep the disparities, but you also don't want to close the disparity and leave the quality bar for the group that was doing okay at first where it was. You want to raise the bar and close the gap. For some people, they need this level of understanding of disparities, otherwise they sort of turn it off. Well, you're just talking about poor people or minorities or this, that, or the other. No, we're talking about everybody most of the time. It's just worse in one group. Now, I did my MPH in Minnesota and Henry Blackburn and some really, I'd say not only impressive people, but people who the lessons they taught me there stuck with me. And one of the things that we were actually taught was that the population disease burden has very little to do with the healthcare system. Actually, I couldn't find the slide to show you, but in general, it's true. It's kind of the way we live is why we see, or where we live. If you have asthma, urban areas, things like that. But at the end of the day, common diseases like hypertension, diabetes, actually treatment of those is so pervasive now that despite increasing levels of physical inactivity and obesity, the average blood pressure level in the population is going down. The average cholesterol is going down, hemoglobin A1C, glycemic control is going down. So the medical system can influence population disease burden, although it's not the responsibility of the system. We're not going to prevent hypertension, for example, in the medical system. But we can treat it, and if we treat it effectively enough, we can actually influence population levels of hypertension. The healthcare delivery system is definitely charged with disease detection, though not necessarily. And here is where we clearly don't want disparities in clinical decision making. We don't want people coming in and when they hear one story from somebody in one social class, racial, ethnic group, or whatever, they say, well, geez, you know, you need to go get cardiac cath, or you need to get a nuclear scan, or you need to get an ankle brachial index, and kind of hear the same story somewhere else from some other person and really just kind of sit on their heels. Now, we do have a problem, quite frankly, of overutilization in the medical system, where people really have just overutilized procedures, particularly ones you can make money off of. There's no question about it. And if I told you anything else, I'd be pulling your leg. We also have some issues where there's underutilization and people are not getting what they need and that's a big crime too. So some examples of racial and ethnic disparities. Here, hypertensive blacks or normotensive blacks basically have the same age-adjusted mortality from all causes in the 25 to 74-year age range as whites with hypertension. The good news is, though, over time with improved blood pressure control, the rates have gone down for both hypertensive and non-hypertensive blacks and whites, but there's still a gap there. The actual, in hypertension, the treatment rates are actually highest for African Americans. The percent who are treated and controlled tends to be lower for Mexican Americans and for African Americans, but it's going up and it's finally broken 50% for virtually everyone. And the overall control rates include people with hypertension who are not medicated, and so the overall control rates are lower. They're more clustered, but they're too low for everyone. Now, Sandy Waddell's probably smiling because I'm going to talk about chronic kidney disease a little bit. We have comorbidity-adjusted targets for blood pressure control. And in the NHANES sample from 1999 to 2006, it didn't matter what race you were, ethnicity, 7 to 8 out of 10 of those individuals, if they had chronic kidney disease, had blood pressures higher than they were supposed to. Okay? So here's a great example. Yes, the Hispanics and blacks are worse off than the whites. It's pretty hard to make a convincing case that the whites are doing okay with chronic kidney disease, because they're not in regards to blood pressure control. And if you didn't have CKD, you saw a similar trend, but also between 1999 and 2006, you saw that more than half of the people were above their goal blood pressure. Again, you see gradients, and you see the minority groups being worse off, but it's not really great for everybody. Heart failure is a very preventable disease, and one of the reasons it's preventable is because we can treat hypertension, we can treat lipids, we can reduce coronary disease. Some of this is going to be done in the population with the diet. Some of it's going to be done in the doctor's office, particularly in higher risk people. So it's very, very preventable, but we have huge disparities, and the disparities even persist when you transplant people. You see that minorities have lower survival rates with transplant. Study I used to be involved in, the Cardiovascular study, showed that African Americans under 30 years have a strikingly greater risk of heart failure over the ensuing 20 years than do whites, with hypertension, obesity, and kidney dysfunction being important factors. We have data from randomized trials that has shown us that in African Americans and whites are similarly treated, the all-cause mortality, death from pump failure, heart not working, and rehospitalization is greater in blacks. And we also have evidence that the heart failure treatment is less aggressive in blacks, meaning that if you need an implantable cardiac defibrillator, if you look at the drug regimens they're on, are they on the right drugs, the beta blockers, the ACE inhibitors, aldosterone antagonists in the right dose, you tend to basically see that African Americans don't get what they should. Now, there is clearly a role for health literacy playing a role in this, or numeracy. There's also a role in the way that we practice, and so when we hold people to quality standards, we really hope to take the incentive out or make it a disincentive to basically give differential care. And finally, if you are an African American and you have heart failure and you get hospitalized with decompensated heart failure, you're a lot more likely to die or manifest a decline in functional status. Now, in my world in hypertension, I see this all the time. Systolic heart failure, diastolic heart failure, and I see people with really, really, really high pressures, and their hearts just ultimately fail. And part of the reason that their hearts ultimately fail is because we don't communicate, get through, and work with them and get them on their medicines and convince them to actually do it. I have a referral practice, and we just looked at data in about 600 of our patients, and about 43% of my patients have resistant hypertension. Ultimately, they fulfill criteria, but in the cut that we took, we were getting about 80% control rates in a very difficult population. Well, geez, I get patients sent to me all the time. Somebody says, they're non-compliant. Well, yeah, they're non-compliant. If you don't talk to them right, you don't treat them right, your staff doesn't treat them right, they get treated indifferently, you make them wait for 2 hours, you always cancel their appointments, and you disrespect them, a lot of times they probably aren't going to pay a lot of attention to you. So what I do is I say, when you come to see me, I want to treat you just like I want my family treated. And when I say that, I think people understand what I'm getting at. I don't need to say any more. I'm not going to cut corners and I'm not getting wild and crazy things because I'm at the university and I like to experiment on people, okay, because you have some folks who are really concerned about that. Here is diabetic retinopathy. Diabetic retinopathy, people over 40 years of age in the United States, men have a little more than women. Non-Hispanic blacks, almost 40% have diabetic retinopathy. Non-Hispanic whites, 26.4%. Vision-threatening retinopathy, about threefold higher, just under threefold higher in the black population. Well, guess what? Retinopathy, we know not only the epidemiological correlates, both elevated glucose, hemoglobin A1C, as well as higher systolic pressure. We also have data that clearly tells us that if you treat the blood pressure, you're going to reduce the need for retinal photocoagulation and laser surgery and blindness. And we also have data that shows glycemic control, probably not as important as blood pressure, but still important for this manifestation of microvascular disease. Well, if you're going to prevent this complication, you're going to have to be real successful. If you don't prevent diabetes and hypertension, then you're going to have to be successful in identifying it and treating it, okay? Otherwise, these conditions, and my family, I give a disclaimer, my family on my mother's side is ravaged with diabetes and complications. So recently when we wrote the consensus statement for the International Society of Hypertension in Blacks, and I chaired that writing group, and we had data from the Accord study, for example, that showed that if you got your systolic pressure down to a target of less than 120 versus a target of less than 140, that there was a 41% reduction in stroke risk. And then we had these so-called experts telling us, well, we couldn't really look at that endpoint because the primary endpoint, which was underpowered, because everybody was on statins or too many people were on statins and the event rate was only half what they expected. He says, well, you can't really look at that because the primary endpoint's negative. And we just disregarded them and we made a recommendation, probably a reasonably timid one, to keep the blood pressure level for people with diabetes at less than 130/80, with the goal of really getting it well below there, so they stayed under there and all.